I'm Dr. Vaishali Gupte, Director Medical at CIPLA, and it gives me great pleasure to welcome you to this webcast on third wave and the role of antivirals, held in collaboration with the Indian Chess Society. There is currently immense rise in COVID-19 cases in India, and we have entered into third wave. Newly emergent mutant variant Omicron has spread globally. Many drugs, newer or repurposed, are being researched for the treatment of COVID-19, and antivirals play a vital role in management of COVID-19. Recently, molnupiravir has been approved for the restricted emergency use for the treatment of COVID-19 and have been shown to reduce the risk of hospitalization and mortality. The objective of today's webcast is to understand from the experts in the field on the role of antivirals in the management of COVID-19 and current status of pandemic. We are honored to have eminent faculty members for this discussion today. Our esteemed moderator is Dr. G.C. Khilnani, sir. He is a professor of pulmonology, medicine, and sleep disorders at India Institute of Medical Sciences, New Delhi. I really thank him for accepting our invitation. Our esteemed panel members and speakers are Dr. D.J. Christopher, sir. He is a professor at Department of Pulmonary Medicine at Christian Medical College, Vellore, and he is the immediate past president of Indian Chess Society. And Dr. Amita Nene, ma'am. She's a head of Department of Respiratory Medicine at Bombay Hospital, Mumbai. I really thank all of them for accepting our invitation. I also thank Dr. D.J. Christopher sir and the Indian Chess Society to give us this opportunity to collaborate with them. With this brief introduction, we will be starting our program now. And I request Dr. D.J. Christopher sir to speak on update on the pandemic and the role of antivirals. Over to you, sir. Thank you so much.
Thank you, Vaishali, for those kind words of introduction. Good evening to you all. I will just share screen and then I will commence my talk. I hope my screen is visible.
Yes.
Okay. So my job is to give us an update on where we are in this third wave of the pandemic and also outline the role for antivirals in this situation. Now we have to quickly look back and see what has been transpiring in the last couple of months. Like the other variants, the mutations in the spike protein have been the key to these variants. Vaccines have continued to prevent severe disease in the previous variants, alpha, beta, gamma, and delta. In this context, very quickly, Omicron, when it came, was declared a variant of concern. Why did this happen? Omicron is a highly divergent variant with up to 32 mutations in the spike protein, which is much higher than with any of the variants. Therefore, there was fear that this could be associated with immune escape potential, higher transmissibility, a different clinical presentation, different severity, and mortality risk. As we speak, almost all these things have been demonstrated in some ways as the cases have started to increase. Now, a key factor that was feared and is still feared and we know is true is that the vaccine effectiveness may not be as well for infection as with the previous variants, but possibly it is retained against severe disease and deaths. These are daily cases looking at the global scenario. These are the previous waves, and the Omicron wave is here. You can see how steep this wave has been, and so that is what we are seeing that is happening in our country as well. We are now looking at the daily deaths, and we know that the previous waves, particularly the Delta, spiral the deaths, and these are the big spikes. And thankfully, commensurate with the high cases that we are seeing here, we are not seeing high deaths. So it is true that the clinical features and the outcome and deaths are different for this variant, and thankfully it is in our favor. I want to take us through another country where this wave has done its rounds, well, not completely, but certainly well ahead of us, to try and understand some things which may apply to our country as well. So here are again the previous waves, and the previous height has been pegged at 100%, the highest reached by the previous waves. And they're looking at case numbers, looking at hospitalizations, confirmed deaths, and patients on ventilator. So as you can see in the previous waves, they all synchronized. When the case numbers went up, hospitalizations, ventilations, and deaths all went up together. Now you see the Omicron wave. And you see the Omicron wave is much higher than all the other waves. In fact, if that was 100% and now it is 300%. So it is threefold higher spike of cases. And the heartening thing is that as quickly as it rose, it has also started to drop. So that's a very hopeful sign that as quickly as we are seeing this spike in our own nation, it could well be that we may also start to see a drop quicker than in the past. Now, this is the patients in the hospital. There's a slight increase, nowhere near the spike we are seeing. Confirmed deaths have not gone up. Patients in ventilator, well, a slight up, but not very remarkable. So we are seeing a dissociation between the case numbers, severity, ventilation, and deaths, which is a good sign. And this is the Indian trajectory. And as we saw the huge Delta wave that we overcame, and now this is the Omicron wave. And as was seen in other countries, this is a steep rise. It would have been much steeper if all the cases are captured, and we know that the cases captured are substantial underestimates, and so this could be much higher than what we are seeing now. But as we saw in the United Kingdom, it is likely somewhere that we will see a dip, and we hope it won't be far from now. So I've just summarized the ground reality as we see in India today. The case numbers are increasing astronomically, that you all will agree. The incubation period is much shorter, often 1 to 2 days. Predominantly upper respiratory symptoms, sore throat, nasal congestion, rhinorrhea, fever, body ache. Hardly any lung symptomatology or ARDS symptomatology in cases. Hospitalizations are going up. ICU admissions in most parts have not gone up as much. And the peak is expected to be sometime in early February and then start to drop. In terms of the Omicron strain, as was expected, I remember the first CME we did in December. So we discussed and we predicted that Omicron will wipe out the Delta variant. And as of now, it is the dominant strain responsible for more than 90% of the cases. And by the time this wave is done, it will, I think, mostly become almost 100%. Now let's look at symptomatology. This is graph from United Kingdom. So this is the patients presenting with symptoms of flu-like illness or cold-like illness, and this is the patients presenting with COVID-like symptoms. So over the past few months, you see obviously cold-like symptoms higher than COVID-like symptoms, and gradually you see that those with COVID-like symptoms have become equal to those with cold-like symptoms. So in other words, every other patient with upper respiratory symptomatology, like a cold, probably has COVID in the United Kingdom. At this point in time, anecdotally, I don't think it is any different. Most of the people we test are turning positive. Of course, the tests are less because the disease is mild, but it's likely that a lot of our colds and upper respiratory symptoms today are from Omicron. Then going back to the very first report from South Africa of symptomatology, I think South Africa did a great job in alerting the world and also giving us alerts on various aspects of this infection. And these are turning out to be very correct. They said that the initial clinical picture was headache, extreme tiredness, body aches, scratchy throat, dry cough, and mostly men under 40s. So this is proving to be quite consistent even in the other countries. This is a detailed symptomatology from UK's COVID tracker app. And 73% are running nose, headache 68%, fatigue 64%, sneezing 60%, sore throat 60%, cough 44%. So below that, everything is lower. Look at smell, which we used to talk much about in the earlier waves. Only 23% have smell affected. So this clinical picture is obviously very different from the previous waves, and this will easily pass off for colds, and we won't be seeing many of these patients in the hospital. Now, we also said that there was fear that there may be higher reinfection with Omicron. So there was some evidence which I want to share with you. This is from South Africa. They looked at 35,670 suspected reinfections. So these are patients who have been infected once and then subsequently diagnosed again to have a reinfection. And so among these people, obviously, all of them had at least 2 infections. 332 had the 3rd infection, and 1 individual the 4th infection. So presumably this is a very immunosuppressed individual to have got reinfected 4 times. So they looked at the relative hazard for the different waves. So second wave versus first wave. They kept the first wave as the benchmark. The relative hazard was 0.75. Third wave versus first wave, hazard 0.71. And the last wave, that is the Omicron wave, early part of it in South Africa, wave 4 versus 1, the hazard was 2.39%, which means that the risk of reinfection after previous infection is much higher than for this wave, the Omicron, than the previous variants. So in the previous variants, people who got infected before received a fair amount of protection, but now we are seeing in our country also that there are people who are getting reinfected much more easily than before. So this study concluded that the risk of reinfection is 3-fold higher with Omicron than the Delta variant. So this has public health significance, that knowledge that this evades immunity from prior infection. So the previous versions did not demonstrate this immune escape. Okay, how about severe disease? So this is again report from the original hotspot, which is in Pretoria, the Tshwane District Hospital, where 42 patients were in the ward at that time when they took stock, and 70% were not oxygen dependent and mostly incidentally detected COVID-19 admissions. So they didn't come in for COVID-19, but they were diagnosed positive for COVID-19. And 30% were on oxygen, of whom 21% had diagnosis of COVID pneumonia. The remaining 4 were on oxygen for other medical reasons. All of them were prescribed steroids as mainstay of treatment, as is the standard of care. So again, we are beginning to see this. We are beginning to see a lot more patients who are diagnosed at hospital, not because they had COVID-like symptoms, but they were screened for COVID. 2 weeks ago, a bronchoscopy screening, 50% of people screened were positive. That's because of the high prevalence in the community. So of 38 adults in COVID wards, 6 were vaccinated, 24 unvaccinated, and 8 had unknown vaccination status. Of the 9 patients with COVID pneumonia, 8 were unvaccinated and 1 was a child. So this, although very small data, is a very interesting and encouraging piece of information. So although people could get reinfected, although there could be breakthrough infection after vaccination, the risk of developing COVID pneumonia seems much higher in those with prior unvaccination status. So vaccine seems to protect against severe disease. And only a single patient on oxygen was fully vaccinated, but the reason for oxygen treatment of this patient was COPD. And at that time, there were only 2 patients in COVID ICU. And overall, these COVID positive patients had a shorter hospital stay, 2.8 days, versus the previous average length of 8.5 days in the previous 18 months. So we are beginning to see this as well. Most people don't even get admitted, and many who get admitted are discharged relatively sooner than before. So conclusion on clinical course: Omicron is highly contagious, no or less respiratory symptoms. Oxygen requirement does not seem high, not requiring high levels of care and often incidentally diagnosed. Infections are going to be high in the next 1 to 2 months. Massive caseloads may mean increase in hospital load by the sheer volume of people. It almost looks like everybody is going to get infected in some form. But by the sheer numbers, the caseload will go up, not because the disease is severe, but as long as the ICU load doesn't climb, which is what we are hoping, I think we should be able to manage much better than the previous waves. I will now dive into antivirals for COVID-19. While vaccines are very attractive prospects and of proven efficacy, we know many nations vaccines are not widely available. So people are beginning to shift their thinking to antiviral drugs as adjunctive treatments for active infections, as well as for post-vaccine breakthrough COVID-19 cases. Now, vaccine is there, but people can break through and develop COVID-19 infection. So antivirals can reduce the risk of progression to severe disease, and that's an important thing. And there are 2 ways we can get new drugs. We can develop novel antivirals for SARS-CoV-2, or we can repurpose existing approved drugs to treat COVID-19. The prime example of this is ivermectin, which I think we have used extensively in our country. Now, it is in this context that molnupiravir has come by. It is an oral small molecule antiviral. It's a prodrug which has been demonstrated to be active against SARS-CoV-2. It is also active against MERS-CoV-2 and influenza A virus, produced originally by Merck and Ridgeback. This is the prodrug EIDD 28001, and when consumed in the plasma, it gets converted to EIDD 1931. And when it moves to the tissue, it gets converted to the final active form, which is EIDD 1931 5-triphosphate. How does it work? It acts as a competitive alternate substrate for viral RNA, and it causes viral mutagenesis and fatal mutations which end up in viral error catastrophes. And this leads to extinction of replication. So I just want to show you the mechanism of this. This is a SARS-CoV-2. As we all know, it enters through the AS receptor into the cell. And you can see this entering the cell. And this is the viral RNA. And these are the substrates on the RNA by different color. They are adenosine, guanine, thymine, cytosine. And these keep recurring in the same sequence. Now, once inside, the viral RNA combines with the ribosomes present within the cell. This is the ribosomes. And then it forms what is called RNA-dependent RNA polymerase. What is the function of this? The function of this is to make copies of the virus and cause multiplication. So that's what happens. It causes viral RNA and copies of viral RNA. And you can see that the copies are exactly the same mirror of the original virus. So this is how it multiplies and spreads within the body. So what happens when molnupiravir comes into the picture? It works on the RNA-dependent RNA polymerase, and then it inserts itself as one of the substrates. Instead of the original substrates, it molecularly being similar looking, it squeezes itself into the virus that is being created. And this creates a mutated virus. You can now, this will now multiply not into the original version, but into a different version. And this will most likely not be viable. And it will end up with what is called viral error catastrophe, resulting in the death of the virus. The absorption and half-life of molnupiravir, the Tmax of molnupiravir is 1 to 1.75 hours with a half-life of 7 hours. The anti-SARS-CoV-2 action of molnupiravir is dose and concentration dependent. So in conclusion, with regard to the molnupiravir drug, molnupiravir is a new antiviral that has become available. We have looked at its mechanism of action by which it outmaneuvers the virus, leading to viral error catastrophes. Now let's look at its role in treatment. First, this is immunodeficient mice implanted with human lung tissue. So all experimental studies, they showed that if it is started 24 hours after exposure, within 2 days, the infectious particles are reduced by a log of 4.5. That is about 25,000-fold. And if the treatment is started later in 48 hours, viral titers reduced by 96%. So there was initial promising animal study results that led to human studies. The first was the phase 1 study, as always happens in healthy volunteers, 130 of them, and it was successful and safe. And then double-blind phase 2 study in 202 subjects. They were given molnupiravir 800 for 14 days versus placebo. On day 3, the viral isolation was in 1.9% with molnupiravir as compared to 16.7% with the placebo. And this difference was statistically significant. So what is clear is that the viral load drops substantially higher with the molnupiravir. And also the time to viral RNA clearance with molnupiravir was 14 days versus with placebo 27 days. So this is again the same phase 2 trials where they use 400 and 800 milligram dose. This is the 400 milligram dose, 800 dose, placebo, and 200 dose. So with the 400 and 800 dose, there was 88 and 98% clearance on day 3. So this is day 3. So 88 and 93% clearance. But on day 5, there is 100% clearance with these 2 doses. So both these doses seem to be okay, but the 800 obviously is better than 400. And that's what we use today. Let's come to the phase 3 trial. It's a global RCT, double-blinded, multi-site study of non-hospitalized adult patients. They all had laboratory-confirmed mild to moderate COVID-19 with symptom onset within 5 days of randomization. All patients were required to have at least one risk factor. This is important. The study was carried out in patients with risk factors. The dose was 1 tablet twice a day for 5 days. So this was the interim results. Hospitalization was 7.3% with molnupiravir. With placebo, it was 14.1%. So around 50% reduction in hospitalizations. And death was 0 in molnupiravir, 8 placebo. We can't make out much with this statistically, the small numbers. But overall, the statistical difference of hospitalization was highly significant, 0.0012. So the data monitoring committee, in consultation with the FDA, these results were impressive enough for them to stop recruitment into the study. And subsequently, FDA took the application for approval. So who are the high-risk groups in this study? Obese people, old age more than 60, diabetics, heart disease were the main high-risk groups. And it's good to keep this in mind as we consider the people that would potentially benefit from the drug. Adverse events, 35% with molnupiravir, 40% with placebo, which means that it was no different between the two. The drug had hardly any adverse events. And even discontinuation, in fact, was lower in molnupiravir group than the placebo group. So the study concluded that molnupiravir reduced the risk of hospitalization and/or death across all key subgroups. Efficacy was not affected by timing of symptom onset or underlying risk factors. Molnupiravir demonstrated consistent efficacy across viral variants, gamma, delta, and mu. These were the variants which were prevalent at the time this study was done. So the efficacy was preserved across these 3 variants. The incidence of adverse events were equal between the groups. So it's a safe drug to take. So there's another study that's ongoing. It's called Move Ahead. It's a multicenter randomized double-blind placebo-controlled phase 3 study looking at the efficacy of molnupiravir in preventing spread of COVID-19 within households. In other words, if patients, as soon as they are infected, take the drug, will it reduce the infection in the households? This is a more recent drug. This is still in preprint. Just came out. So I thought I'll share this with you. This looked at remdesivir, molnupiravir, nirmatrelvir, and a couple of other molecules. These are the molecules they looked at. They looked at in vitro effect of these antivirals on the various strains, including Omicron. And the study concluded that all these drugs retain their activity against all variants of concerns, including Omicron. So these antivirals seem to be working against all the variants, including Omicron. So when more variants of concern arise due to antigenic drift, there is a probability that they may still remain sensitive towards the antiviral. So that's a hope. We do not know. But as of now, all these drugs which were tested in vitro demonstrated efficacy against the variants. Now, there is emergency use authorization for molnupiravir for mild to moderate COVID-19 in adults with positive results. This is the US authorization. And the advice is to take the drug as soon as possible after diagnosis, but within 5 days of onset. Dose is 800 milligrams every 12 hours for 5 days. Molnupiravir has been authorized also for use in the United Kingdom and is being reviewed by other countries as well. So I want to conclude. Molnupiravir is an oral antiviral drug against SARS-CoV-2 that has recently become available in our country. It works by causing viral mutations, which leads to viral error catastrophe and extinction of replication. Positive interim analysis of phase 2 study showed significantly reduced risk of hospitalization by 50%. Incidence of adverse events were equal to placebo, thus well tolerated. It demonstrated consistent efficacy across viral variants, gamma, delta, and mu. It is hoped to be effective against Omicron also. Molnupiravir may be useful for treating patients with comorbidities early and avoid hospitalization. Thank you very much for your patience.
Thank you so much, sir, for such wonderful presentation and giving us this overview of the status of pandemic today, as well as molnupiravir. Thank you. And I now request Dr. G.C. Kindani, sir, to start the panel discussion. Over to you, sir.
Ladies and gentlemen, at the outset, would thank the team CIPLA and especially Dr. Vaishali Gupta and my friend Dr. Christopher for bringing me in front of you. And you just heard a state-of-the-art exposition of antiviral drugs, right from its phase 1 to phase 2 to phase 3. What I'm going to do is with my another eminent panelist, Dr. Amita Nene, to discuss the real-time scenario as to how we should use these antiviral drugs in practice. And I have picked up 2 cases. And please put your question in the chat box as you have been doing, and I have been noting it down. And in the end, we'll indulge into some discussion. So this is a real-time case. A 50-year-old female, she is diagnosed sarcoidosis and being treated by us at PSRI hospital with hydroxychloroquine, and she's on low-dose steroids. She has stage 2 sarcoidosis. She now came with fever for 4 days, cough for 3 days, sore throat for 3 days, and direct questioning also had breathing difficulty for 2 days. She was febrile with a heart rate of 90, blood pressure was normal, SpO2 of 94%, and she actually came on a virtual consult, and she was absolutely in panic. She said, my chest is congested. And this was a CT, the classical of sarcoidosis. You can see the note. This is his previous CT. And Dr. Christopher would agree that this is a biopsy-proven sarcoidosis. So COVID PCR was done, which was found to be positive, and she was in panic. So she was admitted, and when the counts were 10,700 with CRP of 110, D-dimer was 1,724, LDH was normal, ferritin was also raised, PCQ, that is procalcitonin, was normal. The question is 2 questions, and I'll come to Dr. Amita Nene first. Is it possible to differentiate between Omicron variant with other variants, or is it important to do that? I'll come back again, Dr. Amita. What is your experience with this? Please unmute yourself.
First of all, I'd like to really congratulate Dr. Christopher for this fantastic talk. I mean, I think he just covered everything. I'd like to thank Dr. Christopher and Dr. Vaishali and Sipla for inviting me to be here. And I'm very, very happy that Dr. Khulnani is going to be actually moderating the session. So coming to this question, how will we, the first question was that, can we differentiate between Omicron and Delta? Is that correct?
Yeah. Clinically, can you make a sense out of it?
Yeah. So basically, the thing is that in Omicron, as we know, there is more of upper respiratory symptoms in which patients have a lot of throat irritation, scratchiness, myalgia. And if at all they get cough, the cough is productive because normally it's affecting the airways and the lung involvement is less. Having said that, because I work in Bombay, we are a little lucky. And basically, we have labs which tell us whether S-gene dropout is seen or not. So basically, I always get my RT-PCR done from a lab, which will let me know about S-gene dropout or not. So if S-gene dropout is present, that means we 100% know.
If you could restrict your comments to the clinical side of it, because this has not come into practice as yet. We'll come to that part again. Yeah, sure.
Yeah, okay, fine. So basically, very nicely, it was already told by Dr. Christopher that basically Omicron more affects, the symptoms are more of throat irritation, the scratchiness in the throat. They have a lot of myalgia. If there is fever, the fever is only 1 day, maximum second day in immunocompromised patients or patients with comorbidity. And there is basically expectoration usually because it affects the airways. As against that, in Delta, there is more of dry cough. The patient is more sick and the fever lasts little longer. That is what we have actually seen in Delta. And as against that, we have Omicron, which is more of airways.
So, all right. So that's amazing. Something to do with what I experienced that normally, if there are 5 out of 6 people are affected over a short period of time, like 3 to 4 days, 5 members are affected with the mild symptoms. I also tend to feel that it is likely to be Omicron because we know that it's very contagious with a very low incubation period. So this was only, now you can answer this question.
Okay.
Is S-gene drop is reliable? Just briefly, because we'll go ahead.
Very quickly. Actually, the thing is that, it's very interesting. S-gene dropout is also seen in alpha variant. But because we don't have any alpha right now, so currently in today's pandemic, if S-gene dropout is present, then it's definitely Omicron. However, if S-gene dropout is not present, then it need not be Delta because we have BA2 of Omicron, which is now increased to 50%, which normally is not picking S-gene dropout. So if S-gene dropout present, then in today's pandemic times it is Omicron. However, if it is not present, it could be still Omicron or Delta.
All right. So, Dr. Christopher, please unmute yourself. If you were to treat this patient, what should be your choice of treatment?
So, Dr. Khulnani, thanks for putting up a nice case. And nothing like speaking around a real world situation. So, I think this is a patient who, on account of a medical condition, on account of already being immunosuppressed, already a compromised lung from established disease, is a high-risk patient. So we should offer any treatment that could potentially reduce the risk of severe disease in this patient. So this patient will certainly fulfill indications to be treated by antivirals such as remdesivir or molnupiravir. So this person probably, I think I'll stop there as far as the treatment options is concerned.
So the thing is that hydroxychloroquine, ivermectin, doxycycline has been given up. We have remdesivir, molnupiravir, and favipiravir. Dr. Christopher, what about antibody cocktail? Nobody has written on his face that he has got Omicron. So what is your take on that?
Yeah. So I mean, antibody cocktail is extremely attractive and it held a lot of promise. Now with the Omicron, there is sufficient, I mean, there is evidence to suggest that this combination of antibody cocktail will probably not be effective against Omicron. So that being the information, so it has been a dampener in the sense that in terms of the potential of use for this. I think there's only, is it Sotrovimab, I think.
Sotrovimab, that's
yes. Yeah, that is the only antibody cocktail drug that could potentially benefit this group, which we do not have. So as we speak, we are a little handicapped in that area.
What about remdesivir?
Remdesivir is another very attractive proposition. Now, we were using remdesivir in the hospital by the time patients have developed moderate severity and to reduce the severity from progressing further. But a recent trial has shown that treating people high-risk group earlier with a 3-day course of remdesivir reduced severe disease by 87%. So remdesivir is an attractive proposition. The drawback with remdesivir is perhaps a need for hospitalization to administer the drug.
And what about, Christopher, in the interest of time, what about Paxlovid, the combination of nirmatrelvir and ritonavir? Paxlovid is not available with us, but in the interest of knowledge, we should.
Yeah, Paxlovid, I think, was marketed by Pfizer, is another very promising antiviral drug. It will be nice to hope that it will come soon. That's probably the most effective oral antiviral drug reported so far.
All right. So going ahead with the case, this patient was already started on molnupiravir by me actually. It was twice daily for 2 days. She was admitted because she was in panic, and we were also, at that time, we were not sure. She had comorbidities, she was complaining of breathlessness. So we didn't for her remdesivir, rather we thought that it is wise to continue with molnupiravir. She was also started on anticoagulation, that is Clexane, and also moderate dosages of intravenous steroids. And with that, she sort of improved. We have already discussed other options in this case. So what should be the criteria for doing a CT chest, Dr. Amita?
Sir, I'm really sorry, but I just want to say one thing before I answer this question. So going to your case, you said her saturation was 94%. She was a known case of sarcoid. I would have liked to know her baseline saturation before taking this 94% saturation as something to be worried about, number one. And secondly, the saturation was taken when she was febrile. And we all know that when we are febrile, the saturation falsely drops. So I'm somehow not really sure about using steroids in this patient because she was only day 4 of the history. So unless you proved it further.
Okay, I'll answer your question. I got your question. This was already on steroids.
Yes. So we have to just continue the dose. On day 4 of symptoms, when saturation is 94%, when we don't know her baseline saturation, that too when there is fever, we are checking the saturation, means at least is a 2% drop. I would be a little skeptical about stepping up her steroids and giving IV steroids to begin with in this case.
I honor your opinion, but this patient was complaining of breathlessness. We did not know her baseline saturation. She was already on steroids because of sarcoidosis and also hydroxychloroquine. She was complaining of breathlessness. She was admitted in the evening before the CT was done. Since the CRP and D-dimer both were high, it's a clinical decision. We'll have to stop that discussion.
6-minute walk test did we do that time?
Sorry?
A 6-minute walk test?
No, we didn't do a 6. She was admitted late in the evening.
Okay.
And because of the high CRP and the breathlessness and the 94% saturation, awaiting CT scan, we started around 30 milligrams of prednisolone, knowing that she is a patient with sarcoidosis. And so I honor your opinion on that. So we'll have to go ahead. Now the question, criteria for doing CT scan in today's era, Dr. Amita.
Okay, so sir, currently we basically only do a CT chest if we are either planning to start steroids for the patient, whereby patient saturation is less than 94%, or if we are suspecting pulmonary embolism, or if we have another diagnosis which we want to rule out a pneumonia or something. So basically, this patient is already on steroids, and because we don't know her baseline saturation, so I would definitely go ahead with an HRCT chest in this patient, also because
All
she's
right.
hospitalized.
So thank you for agreeing with me on this. So we did a CT scan, but CT scan did not show any evidence of pneumonia. So it's further exemplified that probably this patient had Omicron. And in CT chest, previous residual change of sarcoidosis were seen, but no new parenchymal was seen. And this was a CT scan. You can see that in fact it is much better than the previous one because he has been on treatment. And so this patient responded well to the treatment, was discharged, follow-up of patient was done, and the patient remains stable, maintaining oxygen saturation of 99. In fact, he came in yesterday only, so I thought I will include this case.
Sir, sir, thank you for the wonderful case. One more point: when the patient is a sarcoid, we can't really go by the CRP to decide about the
Absolutely,
patient.
absolutely.
So,
But that CRP was more than 100. And we are discussing the principles of therapy, not the individual decisions about.
correct.
So this is a patient who has got sarcoidosis, who has been on immunosuppressants, including hydroxychloroquine, steroids. When she, such kind of patient, so what I'm summarizing here as a moderator is that if the patient is immunosuppressed or have the 60 plus or have a comorbidity as discussed by Dr. Christopher, when he comes within 5 days, he should get benefit of antiviral therapy or cocktail antibody or both that we are going to discuss if we provided we get some time. So that is the take home message. We are not talking about corticosteroid anticoagulation. That's not the discussion of today, and so we should refrain from that part. The principles of antiviral therapy is today's theme, so that listeners come to know as to when to use antiviral, when not to use. And I must say that this trial with Dr. Christopher described so well was conducted in non-vaccinated people, that we must understand, which are known to have more severe disease. So I'll stop there, go to the second case. This is a 74-year-old female who is a known diabetic, hypertensive with CAD, with post-PTCA, with underlying interstitial lung disease, UIP pattern. She's on treatment for that. She came with fever, cough, sore throat, and breathing difficulty. She was febrile with heart rate of 106, SpO2 of 92% on room air, and then the same thing. We don't know what was her saturation before, and no organomegaly. And so she did a home rapid antigen test done, which came out to be positive, and patient came to ER and was admitted with the CRP of 210. Normal TLC, D-dimer was also high, LDH and was normal, ferritin was high, procalcitonin was normal. Dr. Christopher, is rapid antigen test good enough, or you would like RT-PCR?
I think rapid antigen test will be positive in these individuals, although you don't have a clue to the etiology, to the strain, but it will be positive. I read one report that perhaps the positivity may be a shade lower than for the previous strains.
And of course, the rat is not good for detecting Omicron variant. There was a study from Canada with more than 9 lakh rapid antigen tests which were analyzed, and the false positivity was to the tune of 0.015%. So with that, this is the largest study of rapid antigen test, which says that once positive and positive. But with the rider that if you want to give antibodies, treatment like antibodies, then rat is not good enough. It is recommended to do a RT-PCR. Now, going back to this case, what should be the treatment of choice, Ramita, in this case?
okay,
ILD, steroids,
Yes, sir. So first of all, if those people, because we have infection lab in many cities of India, and it upfront tells us whether SGN dropout is present or not. So if you have the facility, please do the RT-PCR, which tells you about
Now
SGN
that
dropout.
issue has been taken care of. Now
Yes.
we talk about the treatment part.
No, so basically the thing is, if it's Omicron, then I don't even want to think of antibody cocktail. So I think doing a good quality RT-PCR is extremely important. So the thing is that if it turns out to be Omicron, then I'm not going to really entertain the antibody cocktail at all in my mind. And I'm going to give the patient IV remdesivir. And if the patient is non-Omicron, then basically we'll have to discuss with the patient, because very often in a patient who's on immunosuppressive therapy, the symptoms may not be absolutely the way you see them for a proper Omicron or proper Delta. So the thing is that if you have no way of knowing as to what you're dealing with, then I would give IV remdesivir, and I would also still talk about cocktail to this patient.
Okay, all right. So this was a CT scan of this patient, which has a UIP pattern along with ground glassing. So this is a patient who was on treatment from before. Now, Dr. Christopher, is there any role of combining antiviral with antibodies? Making question a little more intricate.
Yeah, it's a tricky question. I'm not aware of anything done as a trial combining the two things. But well, theoretically, I don't see that as a problem. But I think we are delving in an area where we do not actually have objective evidence.
All right. So if I could give my thinking on this, this antiviral and cocktail antibodies have been dumped because we don't have sotrovimab, which is effective for Omicron as well as Delta and other variants. Other thing is that although we are discounting Omicron, but we know that in South Africa, the hospitals became full, ICU became full. The US is still struggling. So we don't know what shape it will take over a period of time and how lightly we should take it. So we should consider this kind of therapy. And although we are hoping that every lab will have facility of determining whether it is a Omicron or non-Omicron, but it's going to take a long time. So in the most severe of the severe cases, if you talk about science and the reasoning, there's no harm in trying both, giving both, because both have an entirely different mechanism of action. And molnupiravir is very good drug, very safe drug, effective drug with 30% or 50% efficacy, but antibodies have its own benefit. As you rightly said, remdesivir is a time-honored viral drug, but it has to begin intravenously, more expensive, patient has to be admitted. I am aware of some centers which are giving remdesivir on OPD basis. They have written in their guidelines, but it has a inherent harm of person spreading, because no way he can travel in isolation. Somebody will have to drive him, he'll be infecting so many other people. So therefore, my thinking is the remdesivir intravenously should be no on the OPD basis, because the fact that I don't think anyway that he may not transmit the disease. Now,
Sir, can I say something, please?
Please.
Yeah, so actually, I don't know, Bombay, we practice very differently. So we basically have home COVID care, and so many of patients getting IV remdesivir at home very comfortably. And at the same time, in Bombay, we have COVID ambulances. Their job is only to pick up the patient, get to the hospital, and take the patient back from the hospital.
All right, if that can be arranged, but everything is not Bombay, We
Yes,
are talking about
everything
about. I get your point, Amita. I got. We understood that if it can be safely done, it is. We have accepted that it is a good antiviral drug, time honored. So for this patient, HRCT was suggestive of CT severity for 17/25. The patient was given remdesivir, steroids, and anticoagulant with other supportive treatment. She was also given antibody cocktail, casirivimab and imdevimab combination, because this is a very, very high risk age, elderly, on steroids and interstitial lung disease with a CT severity score. And this study have already been alluded to with 87% lower risk of hospitalization. The patient got better with treatment and was discharged. She came back for follow-up and asked about vaccination for COVID. So she was already vaccinated with one dose. So Dr. Christopher, how would you advise her for further vaccination?
Okay. Here is a patient who has had one dose of vaccine, and developed disease, and then also was treated with antibody cocktail. So there's a complex interplay of immune responses here. She has immunity from previous first shot. Then she has immunity from disease, and then she has now, and she had the cocktail also. So I'm just wondering whether it can be postponed to after 1 month or beyond, since she already will probably have a fair amount of antibodies. So I wondered whether there's a less sense of urgency to give her that shot immediately.
So, all right. So, wait a minute, Amita, just wait a minute. The consensus is that in a fully vaccinated person, one should wait for 3 months after the infection to get, and there is some, the reason is that there is sufficient evidence that Omicron infection, confirmed Omicron infection after vaccination, after a fully vaccinated person who has received 2 dosages, the immunity which is developed is robust, and that immunity protects against all the variants. So we are finished with the formal. We have only 3 minutes to go, and I'll take 1 or 2 questions. So Amita, can molnupiravir stimulate genesis of more variants? One of the attendees have asked.
Yeah, so it's
because it's a mutagenic.
Yes, so it's a very good question. So theoretically, it is possible because it's causing mutation in the virus, and then it causes the immune catastrophe. And it is possible that if we have rampant use of molnupiravir, then we can actually give rise to new mutant viruses, and therefore we have to be very responsible when we decide to use molnupiravir.
So finally, rest of the questions which were in the chat box have already more or less been answered. And one of the question is, can we use 3-day remdesivir in mild COVID cases with risk factor for progression in India? Does government policies, we are not talking about now, every state has its own policies. And does vaccination status affect decision for antibody cocktail? It's an amazing question. The study which was done with this antibody cocktail actually first tested the antibody of the patient only when they were negative. Then the antibodies were given, but that recommendation has not been followed in our country because of the facilities those are available. And is there a role of antibiotics like azithromycin on OPD patients? No evidence. We are all using it, at least I am using it. I am hurrying up because 7:30 I have another assignment. So ladies and gentlemen, I thank you all, and I will have to take your leave in the interest of going to another meeting. And I give it to Dr. Vaishali Gupta to conclude. Thank you very much, and I am constrained to log off from this.
Thank you.
Thank you.
I thank Dr. Kinnani sir for moderating sessions so well and putting forward such interesting cases and driving such interesting discussions, taking up the audience questions and putting forward all clinically important questions. I really thank him for that. I thank Dr. DJ Christopher sir for giving us the detailed overview of current scenario of pandemic, about the Omicron, its clinical presentations, clinical outcomes, and entire the evidences pertaining to all this, and also telling us about what molnupiravir is, where it should be used, its indication doses, and everything about molnupiravir. Thank you so much, sir. I thank Dr. DJ Christopher sir and Dr. Amita Amini sir for sharing their expert views, their clinical experiences, and addressing the audience queries. And I'm sure this discussion was really helpful to our audience. Thank you, sir, and thank you, ma'am. I thank the audience for spending their precious time with us. And thank you so much. And I also thank the Indian Chess Society for giving us this opportunity. So thank you, Dr. Christopher, sir. And I really thank Indian Chess Society to give us this opportunity for this great educational initiative. Thank you so much.
Thank you.
Thank you.
Thank you.